All right, well, good morning. Thank you for this opportunity to present to you today. The subject of this I got interested in as a practicing physician, as an anesthesiologist. It's so obvious that we're using a lot of stuff. It's coming from somewhere, it's going somewhere as we take care of patients. And so everything we do in healthcare is through the lens of patient safety, what's best for our patients, but also we need to think about what's best for public health at the same time. And that really has just motivated my entire career. So today for learning objectives, I hope that you'll be able to identify a relationship between healthcare pollution and disease burden, understand what we mean by life cycle analysis or assessment, which is how we quantify emissions, summarize just a couple of the latest healthcare pollution findings, and importantly, identify some opportunities for practice improvement, leadership advocacy. And so why sustainability in healthcare? Pollution is a leading cause of morbidity and mortality, responsible for 16% or 9 million premature deaths annually around the world. And ironically, are against the mission of healthcare. Healthcare is a leading emitter of environmental pollution. And reducing healthcare pollution can be great for the triple bottom line. So the best care for the most patients at the least cost. And importantly, another thing that motivates me about this topic is that everybody is touched in their life at some point by healthcare. Healthcare is integral with the global economy. If we can engage health professionals around the issue of healthcare pollution, I really believe this is a key for public policy and societal transformation. So this talk is about climate change. It is not the only global threat. Obviously, we are facing biodiversity loss, land misuse, air pollution is a big problem closely tied to climate change, both stemming from combustion of fossil fuels. Even though we're talking mostly about climate change, we don't want to ignore these other issues. And right now we're living beyond the bounds of the planetary system's ability to rejuvenate itself. Now we can reduce pollution, reduce healthcare pollution by providing less care. That's not the goal. We also have to meet the social needs, which are currently not being met. And so the sweet spot is known as a donut or donut economics, and that is staying within the bounds of the ecological system and above the social foundations. And so this talk is mostly about climate change. The Intergovernmental Panel on Climate Change, which is the global scientific body, a special report in 2018, and really the same message every year, that business as usual is going to lead to, by the end of this century, or average global rise of 4.1 to 4.8 degrees centigrade. This is the uncertainty. Our current policies have us between 3.1 and 3.7%. The pledges, including the Paris Accord, between 2.6 and 3.2. That's not enough. In fact, the recommendation, the aspiration of the Paris Accord is a 2 degrees centigrade warming pathway. And really, if we want to limit the worst predicted harms to civilization by the end of the century, we have to aim for 1.5 degrees centigrade. We're already, in fact, I can't keep my slides updated fast enough. We're already at 1.2 degrees centigrade average warming, surface temperature warming since pre-industrial times. We're likely to reach 1.5 degrees centigrade closer to 2030. So the mandate is to essentially have emissions by 2030, get to net zero by 2050. This is possible within the laws of physics. We had the big anthropause with the COVID pandemic. It is absolutely possible. It is really about political will. And so nobody's death certificate or nobody's diagnosis is ever going to say climate change. Climate change essentially exacerbates underlying health threats, introduces new challenges, disproportionately impacts more vulnerable populations, and affects the social determinants of health, right? So by misusing land, by excessive combustion of fossil fuels, we're increasing temperatures, we're driving more extreme weather events, whether it's drought in some locations, flooding in other locations. We're having more extreme heat days, poor air quality. All this is affecting food and water security, changes of patterns of vector-borne illnesses, and population displacement. The vast majority of the world's populations live along the coasts. So with sea level rise, it has been predicted we could see as much as 1 billion displaced people by 2050. And then the health outcomes with more heat-related heat exacerbations and, for example, more cardiopulmonary illnesses, food, water insecurity leading to diseases and so forth. And of course, mental health consequences and stress, political instability. And of course, some populations are more vulnerable than others. And so not everybody experiences these things equally. And how climate change affects healthcare. So we're seeing more of these diseases and deaths related to these events, but also disrupting our ability to deliver healthcare. And again, it's impossible to keep up with these. Hurricane Sandy, I live in Connecticut, so was absolutely affected by Hurricane Sandy. In the year prior, Hurricane Irene, these 500-year events, 2 years in a row. Famous pictures from Lango Medical Center evacuating a neonatal ICU, which was on the 9th floor. On the right, the great campfires in California. This is the emergency evacuation of the Feather River Hospital, which burned to the ground, like caught fire shortly after they succeeded in evacuating and burnt to the ground. So climate change is not only increasing the disease and disability we're seeing, it is disrupting our ability to deliver care. So that's how climate change, in a snapshot, affects healthcare delivery. But how does healthcare delivery contribute to climate change? So we're a huge part of the economy, 4.1 trillion in the US, 1/5 of our economy is just to healthcare. Hospitals are the biggest driver of the emissions within the healthcare system. We run 24/7, high-tech diagnostic therapeutic equipment, unique infection prevention requirements like no other industry. We have enormous regulatory complexity and business models that are driving wasteful, unnecessary utilization of resource. And we are a very wealthy nation and a very wealthy system. We have a culture of excess, candy store culture, things appear free, and where disposability is normalized. And our social mission is to take care of our patients. We feel very good, no holds barred from taking care of our patients. But as I started with this, we have to also simultaneously think about what's happening to public health. And so this is our work with the Lancet Countdown on Health and Climate Change. So I talked a bit about US healthcare. Globally, healthcare is 10% of our global economy. Globally, 5.2% of global emissions stemming just from the healthcare sector and rising. The US is an outlier, not in a good way here. We are 25% of these global emissions just coming from the US, even though we are 4% of the global population. So we have the highest per capita greenhouse gas emissions of any nation. Now, if we had the best health outcomes, there might be some justification for that as we figure out how to clean up our energy sources and find better ways of doing business. But we do not have the best healthcare system in the world. About 1/3 of healthcare services are deemed low value or inappropriate. 10% of the US population is presently uninsured. And we can see if we associate the per capita healthcare greenhouse gas emissions with a measure of healthcare access and quality. We've done this with many different measures and outcomes. We've also done this with the Human Development Index. This year is with Healthy Life Years. The report will be coming out in October. But if we associate healthcare greenhouse gas emissions with the Healthcare Access and Quality Index of the Institute for Healthcare Metrics in Seattle, Washington, we see that there are many nations who have better performing health systems than we do, and with far less greenhouse gas emissions per capita of healthcare. And the break-even point is around 400 kilograms per capita of healthcare emissions. We're about 4 times that in the US. The good news is that we can reduce our healthcare emissions without sacrificing and even improving healthcare access and quality. And so it's not just greenhouse gas emissions or other emissions. Most notably, air pollutants are particularly noxious in short term to human health. 8.5% of our nation's healthcare emissions, greenhouse gas emissions coming just from healthcare, the healthcare sector at about 9%, similar fraction coming from toxic air emissions, notably PM 2.5. If you account for both greenhouse gas and non-greenhouse gas emissions, health damages from healthcare pollution right now are around 388,000 disability-adjusted life years lost, especially from particulate matter. And this is actually similar in magnitude to harm from medical errors as first reported by the Institute of Medicine, now the National Academy of Medicine. Famous to Err's Human report, on average, these premature deaths lost about, the actuaries tell us, about 10 years of life lost. So if you multiply, but they're different metrics, but if you multiply the years lost by 10, we are in the same order of magnitude. So the two Err's Human report sparked the patient safety movement. Everything we do now in healthcare is through the lens of patient safety. We would not have it any other way. And what we're trying to say is health damages from healthcare pollution are similar in magnitude as from medical errors, and that pollution prevention is a new patient safety movement. And so we need to understand where those emissions are coming from to be able to have an impact. Multiple national studies of healthcare systems come up with the similar findings. This is from the NHS, it's similar in the US, it just is a nice graphic. About 70 to 80% of emissions are coming just from the supply chain, the goods and services that we use to deliver the care, especially pharmaceuticals and chemicals, medical equipment and supplies, and food. These are things we have direct influence over as clinicians. So if we think about how we're going to reduce healthcare pollution, we have to address consumption. So the things that clinicians, administrators, regulators, we control appropriate and inappropriate consumption of resource. The other are the emissions intensity, or what's embedded in the products and the goods and services that we use to deliver care. Manufacturers, regulators, they control what go to marketplace. This is where our advocacy and leadership role comes in. This is where, at all levels, our clinical practice, advocacy, and leadership come in. So just very briefly, even though this is about climate change, I just want to mention there are more than 100,000 industrial chemicals in existence. They are not regulated the same as pharmaceuticals. There is no burden of proof of safety before they go to the marketplace. There is effort to reverse that burden of proof, particularly coming out of Europe. What's called the precautionary principle, that safety has to be proven first. But the cat's out of the bag on these chemicals. They are ubiquitous across the earth. This is a famous study by the Environmental Working Group that looked at newborn cord blood samples across the United States, looking for 267 at that time, this is more than 20 years ago now, chemicals of concern. It was a small study, but shockingly, every single one of those newborn cord blood samples across the United States had virtually every single one of those 267 chemicals. In other words, babies are being born polluted. And the healthcare industry is a leading purchaser of chemicals, not just cleaning, but all the stuff that goes into manufacturing everything that we use. And so addressing inappropriate consumption is an important, and finding safer ways of making things and using things is part of our responsibility. And just a word on plastics. Plastics are derived from fossil fuels. There's a massive lobby to try and promote more consumption of plastics. The World Economic Forum has estimated that, again, business as usual, there will be more plastic volume than fish in the ocean by 2050, not just on the surface. There's no magic machine that's there is a machine that can clean up some of this, but it's also at the bottoms of the oceans. And it's not just the macroplastics, it's the microplastics. You've probably seen this is now big news. Again, hard to keep up the literature. Microplastic pollution, ubiquitous in tap water and table salt, found in stools in humans, also wild animals. And found in blood in the lungs. And we don't really know all the damages that are happening from this. We do know these plastics are laden with chemicals, notably hormone disrupting chemicals that impart desirable characteristics of plastic, things like pliability and our IV tubing. These chemicals many of them are ionically bound, so they leach off and come off very quickly in contact with lipids, with heat. So many of our products in healthcare are laden with these chemicals, and a single IV exposure, you can measure these chemicals in the urine, a single fluid exposure. And so a lot of this plastic growth and single-use disposable growth is in the name of infection control. Obviously, healthcare-acquired infections, it's part of our patient safety lens. We must prevent infections. It's the most frequent adverse event in healthcare delivery globally. Already old data, but nearly $7 billion lost in the US due to healthcare acquired infections. 7 in 10 in high income nations, 7 in 110 in developing nations will develop at least one healthcare acquired infection. So this is the excuse of why everything's becoming disposable. I don't know, how many have been in the hospital environment recently, but everything's becoming disposable, from blood pressure cuffs to pulse oximeter probes to pillows and linens to complex surgical instruments. There is by and large a dearth of data to support this trend. Obviously, it is all important for every one of us to prevent infection. If patients get infections and they need more health care, they need more procedures, that also drives up pollution, drives up costs. But we have to be very careful about what actually is evidence-based. And as we learned, we've got a global supply chain. So going back to, we tend to know maybe our direct suppliers. We probably don't know who their suppliers are, where the raw materials come from. So globalization can reduce production and storage costs and local pollution, but we're actually exporting our pollution. Unfair wages is a huge problem. So there's a question of, is this global supply chain just? We need better control over it. There's lack of transparency of supplier risks to climate change and also to pandemics. So the risks are the same. As we've seen with the COVID pandemic, we are so reliant on this global supply chain. Every one of us is at risk, high income, low income nations. On the left, this is an image from Brooklyn, New York. On the right, this is from a hospital in the UK. These are very wealthy hospitals, nations. We've been caught with our pants down. And of course, the PPE, personal protective equipment like that, made headlines, but it was also ventilators, video laryngoscopes, drugs for sedation, dialysis supplies. So many things were on shortage. And whether we're talking about pandemics or climate change, the risks are very similar to supply chain disruption, and the solutions are very similar. So let's talk about very briefly, what is a disposable medical device? It's actually an industry label. Just because something is labeled single use does not mean it can't be reused. That's very important to know. What it does mean is whoever cleans it assumes the responsibility for risk that it functions as if it's new. This is a part of manufactured obsolescence to drive consumption as a business model. There are ways, there's a whole industry called reprocessing that can take these devices and clean them and reuse them. In fact, we had to urgently do that. I apologize, I'm jumping ahead in slides. We'll come back to that. But importantly, the causes of infection are multifactorial. Whether or not we have good staff discipline with aseptic, antiseptic practices, patient health status, whether or not they're immunocompromised, have diabetes, the exposure site, the quantity and the virulence of the organism, and so forth. And most importantly, we know the two most important things are proper hand washing and host defenses. And we are not going to cure either of these issues with single-use disposable items. We can cross-contaminate with a disposable item just as clearly as we can with a reusable item. And this is just an example of surgical site infections as one type of infection. It used to be that if you go back in time to the 1800s, if you had a major operation like a leg amputation, you had about a 95% chance of getting a fatal infection, about a 40% chance of surviving that infection. And then along came Semmelweis, Pasteur, Lister, germ theory, antiseptic, aseptic technique. That was the most important change in the history of medicine that reduced infection rates and improved survivability. Then around between the First and Second World War, the introduction of antibiotics, and now we are asymptotically approaching zero. You have about a 95% chance of survival, less than 5% chance of infection, and much even better than that. So we're asymptotically approaching zero infection rates, or aiming for zero harm being, the big mantra. But we're throwing everything at it. We're increasing consumption of both reusables and disposables, ignoring this hidden and increasing burden on public health. And so really we have to be much more mindful about how much we really need to throw at this issue. And the goal of zero healthcare acquired infections, the goal of zero harm is not attainable, and it's causing indirect harm and needs to be rethought. Sorry, this is a slide I meant to show earlier, a little out of order. With the COVID pandemic, we've had to reuse disposables. We've had to resort to reusables. These are just some examples of some of the most common devices that were on shortage during the pandemic. We figured out how to do this safely. Now, many of these things are not designed for reuse, but they can be. And so it really begs the question, what's the difference between a single-use and disposable item if we can reuse disposables safely? And so we really need to shift our mindset. So there's this concept of the linear economy. What we have is, of the circular economy. What we have is a linear economy where we extract materials, we make something, we use it, we throw it away. The concept of the linear economy is taken from nature. In nature, there is no such thing as waste. Waste is the feedstock of another system within an ecosystem. So the idea is to redesign products and services with fewer embodied chemicals and waste, extend the life of products, recover materials, repurpose, and then address the drivers of manufactured obsolescence. So we need to retain and reuse, reprocess, and reduce. Recycle is the last strategy. It's better than nothing, but it is not the solution. And so life cycle assessment is a method of quantifying emissions across the entire cycle of a product or service, from material extraction to manufacturing to use, and what happens when we throw it away. This considers the entire system. It's not necessarily intuitive where the emissions are most problematic. And importantly, even though we talk a lot about carbon emissions, it's not the only pollution of concern, and we have to be careful not to shift one problem to another. And so we use this to model emissions to help us make decisions, whether it's addressing one area of the manufacturing chain or the waste management chain, or it's going for an alternative product altogether. Just very briefly, this is one device that I use in my practice, a laryngoscope. There are thousands of devices we use in a healthcare system on a daily basis. There was this whole wave that we needed to go to disposables for infection control reasons. That has not been borne out, but nonetheless, we were being forced to do so, mostly for fear of citation through the Joint Commission. That's a whole nother lecture. There's a lot of information here. Just want you to squint at it, looking at the blades and the handles separately. Gray is disposable, the green are the reusable scenarios. Some take-home messages here, including disposables have several times the emissions of the reusable. We use tens of thousands of these devices just in my one hospital every year. This is just one device, just one hospital. So disposables increase the emissions several-fold. Now people, and in fact, industry says, well, we'll have this take back program, you can recycle it, you can feel good, it's okay. Well, the red is the waste phase portion of the emissions. And so we modeled the standard US mix. So a fraction gets recycled, a fraction gets incinerated, a fraction gets landfilled. But just to address this issue of recycling, we asked the question, what if you could 100% recycle these devices? It is not possible, but we looked at the extreme, what if you could? That's where these bars are. So in other words, we cannot recycle our way out of this problem. Recycling is better than nothing, but we really need to shift back where it's safe to do so to reusables. And just squinting at this again, these are the costs, the gray being the disposables, the green being the reusables. This one device shifting to disposables at my one hospital, my one department, increased our costs by about $700,000. So there's a concern, well, we don't have the staff to clean these things. Well, it turns out that we reprocess 12,000 instruments a day. This would have increased our needs by about 1%. And we could certainly hire staff to do so if we didn't have to hire staff. So we actually went back to reusables. There's also concern these things get lost. We did a break-even analysis. The devices are rated for 4,000 uses. That's what we based it on. You'd have to get about 5 to 7 uses of the reusable to break even with the cost of a disposable. And if you can't get more than 5 to 7 uses out of a device that's rated for 4,000 uses before it's lost, the answer is not disposables, it's to retrain the staff. And so just very quickly, another concept, this idea of clinical equipoise. So if you have, that was an example of device, we could do same thing for drugs. If you have different clinical approaches to the same outcome, clinical equipoise, we don't often, but what if we did? This is just an example from my own field of anesthesiology. A patient can go to sleep by breathing gas, general anesthetic, or they can get a general anesthetic by getting intravenous, called total intravenous anesthesia. They can get a peripheral nerve block. This is an example of somebody getting their arm numbed up, or this is an example of someone getting spinal anesthetic. So different approaches to anesthesia. Sometimes we have choices. Again, just squint at this. We know inhaled anesthetics are potent greenhouse gases. We hypothesize that any anesthetic approach that use inhaled anesthetics would be much more significant in terms of emissions from the environment. That is borne out. So if we have a choice to do another way from an environmental perspective, we should avoid inhaled anesthetics. This is just an example of a clinical care pathway approach. So, and then just to come to give some time for my colleague to give her talk, there's this idea of net zero emissions. We talked about this mandate to have emissions by 2030, get to net zero by 2050. The NIH, excuse me, I hope it's the NIH soon. The NHS, National Health Service in England, is the global exemplar. They have legal mandate to reduce their emissions according to those timelines. They have an entire division dedicated to measuring and strategically guiding decarbonization. My research team has been part of particularly the assessment of the supply chains to project to get to net zero. And then, of course, at the annual climate change conference, the COP event at 2026 this past November, more than 51 nations have committed to climate resilient healthcare. This number is growing. We need to all get on board with this mandate. And so finally, I would say that this idea of net zero healthcare, there's this concept of a planetary healthcare framework. We've talked about much of this, not all of this. We talked about reducing emissions embodied in healthcare services. We didn't get into, we need electrification of all our facilities and equipment that must be paired with clean energy. We talked about the circular economy. We need to keep resources, we need to reduce waste, keep resources at their highest value and use. We need to be better stewards of the resources that we use. We need to stop wasting them. We have to match supply with demand, this concept of avoiding inappropriate care. If patients want a test or they want a procedure, it's not simply enough because they want it. Is it going to achieve a desired effect? And it's the same thing as a clinician. We need to avoid tests and treatments just because maybe it won't hurt, maybe it makes us feel better. We have to avoid this inappropriate care. We know inappropriate care is a global issue. It's an issue here in the US. 1/3 of our resources.
Turn on the video now.
Finally, we need to reduce the demand of healthcare. We need to move upstream. Health promotion, disease prevention, address the social determinants of health, this concept of what is value, highest value. We talked about the triple bottom line. We're expanding this notion. It's not just the best outcomes for the most patients at the least cost. We need to minimize environmental and social harm. And with that, I'll turn it over to my colleague.
Well, Kate's pulling up my slides. Thank you. Good morning, everyone. My name is Elizabeth Finkelman, and I'm a Senior Program Officer at the National Academy of Medicine, where I oversee our Grand Challenge on Climate Change, Human Health, and Equity. Many of you are probably familiar with the National Academy of Medicine, but we are formally the Institute of Medicine, as Jody mentioned, and one of the 3 academies that make up the National Academies of Sciences, Engineering, and Medicine. We were established in 1863 by congressional charter, and so the academies are a private nonprofit institution that work outside of the government to provide objective advice on matters of science, technology, and health. So we advise, convene, and catalyze, and through our independent reports and recommendations, we inform the future directions in health and medicine. And so it is with this mandate that the NAM has launched a grand challenge on climate change, human health, and equity, recognizing that climate change is among the most important and urgent global health threats and opportunities of our time. And so during my presentation today, I'll provide an overview of the vision and programs of the NAM Climate Grand Challenge, but we'll focus in particular on our work on decarbonizing the US health sector, building from Dr. Sherman's presentation, which you just heard. So we go to the next slide, and I'll be reinforcing some messages from Dr. Sherman's presentation. So It is well established that rising levels of greenhouse gas emissions, which cause climate change, are influencing a host of health-related issues. And as shown here in the figure from the WHO, climate change impacts human health and well-being in a multitude of ways and through different exposure pathways, many of which Dr. Sherman discussed. So climate change has obviously led to increases in the frequency, severity, and duration of extreme weather events, such as high heat, increasingly severe and devastating wildfires, hurricanes, and tornadoes, all of which threaten human health by exacerbating underlying medical conditions, increasing stress, and producing adverse mental health effects. And extreme weather events, of course, can also disrupt healthcare infrastructure and delivery systems, as well as public healthcare services. So during and after the event, which obviously can have adverse health outcomes for patients. And with climate change, we're obviously seeing higher temperatures and more heat, especially in the summer months, like right now, which are associated with an increased risk of a range of illnesses and death, particularly among older adults, pregnant women, and children. Increasing air pollution, which leads to worsening air quality, of course, has major health impacts. Air pollution is linked to some 7 million annual deaths globally and over 100,000 deaths here in the United States. Of course, rising temperatures and changes in weather extremes also stand to have major impacts on quality and availability of water and food. Rising concentrations of carbon dioxide, for example, are already known to cause changes to the nutrient content of agricultural crops, as well as seafood and fisheries. And then, of course, climate change is linked to changes in vector distribution and ecology, and as such, changing patterns, transmission, and incidence of infectious disease and chronic disease. And of course, we've already witnessed the devastation caused by COVID-19, but climate change could make infectious disease outbreaks and pandemics even more likely. If we go to the next slide, of course, across the globe and here in the United States, the health threats and impacts of climate change are not equally or fairly distributed across populations or geographies. Rather, they disproportionately affect people living in the most vulnerable, under-resourced, and disadvantaged environments. And so as illustrated in this diagram from the 4th National Climate Assessment in the United States, children, older adults, low-income communities, and communities of color disproportionately experience health-related impacts of climate change due to ongoing and historic systemic inequities. And so as a result, these populations have fewer resources to prepare for and respond to and cope with the impacts of climate change on health. And in many ways, climate change exacerbates existing health and socioeconomic inequities, and many consider it to be a driving factor of health inequities more broadly. So given the scale of this crisis, NAM has identified it as a grand challenge for us to take on as an academy, as well as for the broader health community. So if we go to the next slide, the Grand Challenge is a multi-year strategic initiative that we launched last year. The vision of the Grand Challenge is to improve and protect human health, well-being, and equity by working to transform systems that both contribute to and are being impacted by climate change. The initiative has several strategic objectives. The first is to communicate the climate crisis as a public health and equity crisis. The second, to catalyze the U.S. health sector to reduce its carbon footprint. The third, to develop a roadmap for systems transformation. Fourth, accelerate research and innovation at this nexus, and of course, reduce climate-related health inequities. And so these objectives correspond to a set of programmatic pillars of the initiative, which are described on the next slide. So if we go to the next slide, the first programmatic pillar focuses on messaging and communications. So public awareness of the health impacts of climate change is relatively low. A recent research by EcoAmerica indicates that protecting personal and public health is actually a leading reason among Americans to support climate solutions. And so given this, we see an opportunity to leverage our reputation and independence to communicate and elevate the impacts of climate change on public health and equity, including evidence-informed opportunities for mitigation, adaptation, and resilience. And in addition to policymakers, we see healthcare leaders and practitioners as key audiences to engage through this messaging, which I'll discuss in presenting the work of our Action Collaborative. And the Action Collaborative on Decarbonizing U.S. Health Sector is our second programmatic pillar. It's a public-private partnership convening leaders from across the health sector to reduce the carbon footprint of the health sector and strengthen its resilience. Our third pillar is our roadmap for systems transformation. This will be a consensus report that provides the vision and recommendations for how major systems such as agriculture, transportation, and energy might be redesigned to promote a more equitable, health-promoting, and climate-sustaining economy. We have a fourth programmatic pillar that focuses on mechanisms to accelerate research and innovation at the nexus of climate change, human health, and equity. given that historically there's been limited public and private sector investment in research at this nexus, and funding streams have largely remained siloed. So we see significant opportunities to leverage our neutral convening capacity to bring together funders from across the federal government, as well as the private sector, both here in the US and globally, to identify opportunities for accelerating research funding and investment in this space, and to help coordinate and guide a strategy for doing so. And then finally, because addressing climate-related health inequities is a central tenet of our grand challenge, early next year, NAM will be launching a climate communities network of community-based organizations and leaders representing those who disproportionately experience the worst health-related climate impacts. And members of the network will help inform the directions and outputs of the Grand Challenge programs, while providing a space for community leaders to address common challenges, co-design solutions, and identify opportunities for research, policy, and funding that will improve their health in the context of climate change. So I'm going to spend the rest of my presentation talking about the NAM's Action Collaborative on Decarbonizing the US health sector. As I discussed at the beginning of the presentation, the climate change is increasingly affecting people's health, which has direct consequences for the healthcare system. Yet at the same time, as Dr. Sherman underscored, the healthcare system is contributing to climate change. Healthcare accounts for nearly 20% of US GDP, so it's a major consumer of resources, and as a result, a major producer of waste and greenhouse gases. The US health sector alone is responsible for 8.5% of US carbon emissions. These emissions stem directly from the operations of healthcare services, which are referred to as Scope 1 emissions, purchased sources of energy, heating and cooling, Scope 2, and then the supply chain of healthcare services and goods known as Scope 3. And compared to other health systems globally, the US is among the top emitters of carbon alongside China and the European Union, and is actually responsible for about 25% of global health sector emissions, which is the greatest proportion among all health sectors globally. If we go to the next slide, of course, these emissions stand to have major impacts on human health, which the system is supposed to protect. Obviously, as Dr. Sherman noted from her work, the disease burden associated with the health sector's emissions has been estimated to be on the same order of magnitude as deaths from preventable medical errors. And then, of course, these impacts are and will continue to disproportionately affect people of color and other populations made vulnerable by systemic inequities. And beyond the human toll, there's a major financial toll of climate-related health impacts. The WHO estimates that climate costs to human health will be on the order of $2 to $4 billion per year by 2030, and the true figure is likely even higher. So it's clear that addressing the carbon footprint of the health sector and all sectors really is a major opportunity that will have clear health, social, and economic benefits. So if we go to the next slide, so given all of this, last September, NAM formed and launched the Action Collaborative on Decarbonizing the US health sector. It is a public-private partnership convening leaders from across the health sector to co-develop and implement a shared action agenda to reduce the carbon footprint of the health sector and strengthen its resilience to climate change. The collaborative focuses its work around 4 core priority areas: the healthcare supply chain, healthcare delivery, health professional education and communication, and policy, financing, and metrics. And altogether, the collaborative has about 70 participating members right now, representing hospital systems, healthcare accreditation, health professional associations, private payers, the biopharmaceutical and medical device industry, healthcare distributors, health professional educators, academia, nonprofits, and the federal government. So you can see we have sort of an expansive and wide-ranging membership to really drive this unified agenda. So if we go to the next slide, this just shows you an overview of the Action Collaborative structure. It's guided by a steering committee that oversees the strategic directions of the collaborative and its core activities. Our membership, those 70 participants, are distributed across 4 working groups, which correspond to the 4 priority areas I mentioned before. So healthcare supply chain, healthcare delivery, education and communication, and then policy, financing, and metrics. And we also have network organizations to the Action Collaborative, who are essentially affiliate organizations. They don't participate in the day-to-day work of the Climate Collaborative, but really serve to both help inform the work of the collaborative and extend the reach and impact of its work. And to date, we have around 60 organizations participating in the network, but the opportunity remains open for people to join. If we go to the next slide. This slide just shows the membership of the steering committee to give you a flavor for the level of leadership and diversity of perspectives that are working together on this. You'll note that the steering committee is co-chaired by Dr. Victor Zhao, who's the president of the NAM, Admiral Rachel Levine, the Assistant Secretary for Health at HHS, which obviously her office has recently launched OCHE, so the Office of Climate Change, Human Health and Equity, just last year as well. So we're working very closely with them, as well as on their efforts related to health sector decarbonization. Andrew Whitty, who's the CEO of United Health Group, is another one of our co-chairs, as well as George Barrett, who's the former CEO of Cardinal Health, obviously a major healthcare distribution company. We also have the co-leads of our 4 working groups serving on the steering committee, which really facilitates coordination and alignment across their work. So if you go to the next slide, I'm now just going to briefly go through the working groups and describe their priorities and plans, starting with healthcare supply chain. So the healthcare supply chain encompasses the production, transport, use, and disposal of goods and services that the sector consumes. Globally, the healthcare supply chain is responsible for about 71% of the health sector's emissions. And in the US, the supply chain accounts for a little bit over 80% of the health sector's carbon emissions, with pharmaceuticals and chemicals being the largest contributor. So as these figures indicate, there's tremendous opportunity to reduce the health sector's footprint by focusing on the healthcare supply chain. But it's important to acknowledge that across these industries, there is already a movement towards reducing emissions and waste through expanding ESG initiatives. But some challenges remain to more substantial progress that we've heard. So first, these are global industries with many inter and codependencies, which can make progress challenging and slow. Healthcare suppliers vary greatly in terms of their size and scale, and as such have varying degrees of resources to do this work. Across companies, there's inconsistency across emissions metrics and reporting structures. There have been relatively few inquiries or incentives to accelerate innovation in sustainable manufacturing processes, product and packaging life cycle analysis, as well as product end-of-life solutions. There remain challenges fitting new products and technologies into some of our existing regulatory frameworks, practices, and concepts, and the reapproval process for products previously approved but have been made greener can still be long, cumbersome, and quite resource intensive. So if we go to the next slide, in light of all this, the supply chain working group seeks to help scale resources and best practices to help healthcare suppliers decarbonize, to highlight policy and regulatory challenges and solutions to decarbonizing the healthcare supply chain, and to help foster alignment around metrics, accounting, and reporting standards. And so over the next year, the group will be putting out a few products, including a digital climate journey map and resource repository to help supply chain companies start or accelerate their sustainability journeys. They will also be putting out a series of papers and case studies, one looking at opportunities to expand digitization and reduce paper waste, looking specifically at patient package inserts as one area of opportunity. Another that will look at the challenges, barriers, and needs for fulfilling emissions accounting and reporting requirements. And a third looking at how we can better minimize waste in healthcare packaging and develop more circular solutions for healthcare products. We go to the next slide. The health sector's scope 1 and 2 emissions amount to just under 20% of the sector's total emissions, making healthcare delivery another clear area of opportunity for decarbonization and the focus of one of our working groups. It's important to note that several hospitals and health systems across the United States are already moving to decarbonize, including Kaiser Permanente and Providence St. Joseph Health, among others. And certainly organizations like Healthcare Without Harm have been important in helping galvanize this movement for HCOs. However, on the whole, decarbonization initiatives across the health systems more broadly have been limited. Some of the challenges we've heard include that there's a lack of a business case or financial model for decarbonization, that there are insufficient financial or payment incentives for doing this, that there's a lack of shared or commonly accepted measures, and that there's inconsistency and variability in measuring and reporting emissions. So going to the next slide, to address some of these challenges, the Healthcare Delivery Working Group is focused on building a multifaceted case for decarbonization for C-suite leadership at healthcare organizations. So really unpacking and describing why healthcare leaders should care about decarbonization and what it means for them. They're looking at how to identify a core set of sustainability metrics for healthcare organizations, assembling best practices and playbooks to support HCOs in decarbonizing, and highlighting policy and regulatory challenges and solutions as well. So if we go to the next slide, many have observed that clinicians are uniquely positioned to communicate and elevate the health impacts of climate change, given that clinicians are among the most trusted and respected professions. And across clinician groups, there is certainly heightened recognition that climate change is impacting the health of patients and communities. Yet on the whole, most clinicians still have limited training on the linkages between climate change and health. And while new programs on climate and health are emerging across clinical education, they are still quite limited in numbers and scope. So moving to the next slide, the Action Collaborative's Health Professional Education and Communication Working Group really aims to seize on this opportunity. And in particular, they're focused on identifying knowledge gaps on climate and health among clinicians and healthcare leaders and administrators more broadly, mobilizing support for decarbonizing healthcare as well as greater climate and health education, scaling existing climate and health curricula and educational programming for health professionals, and looking at opportunities to expand curricula and other educational opportunities across the education continuum. And so the working group is in the midst of planning a series of focus group listening sessions, as well as a meeting of health professional education leaders to address these areas, which will take place between the end of this year and into next year. And then moving to the next slide, finally and fundamentally, of course, progress across the healthcare supply chain, healthcare delivery, and education and communication will really hinge on having supportive policies, payment and financing, as well as transparency and accountability through reported metrics. And as such, policy, financing, and metrics, as you've heard, are addressed individually across our working groups and coordinated and integrated through a fourth working group, which actually includes members of the other three. So if we go to the next slide, the Policy, Financing, and Metrics Working Group is creating an integrated and cohesive policy and regulatory agenda for decarbonizing the health sector based on those barriers and opportunities that are identified by each of the other three working groups. And this policy and regulatory agenda will take the form of a paper series that will roll out next year. They're also looking at identifying financing mechanisms and pathways to support HCO decarbonization, given that that appears to be a major limiting factor. And so those opportunities will be also laid out in a discussion paper that will come out either later this year or early next. And then, of course, they're looking at supporting the identification and implementation of decarbonization metrics for HCOs, which we're doing with some of our partners, including the Institute for Healthcare Improvement. So if you go to the next slide, in summary, the climate crisis is a public health and equity crisis, and climate change will continue to have profound impacts on human health and well-being, if both here in the United States and globally, if left unabated. And bold new approaches to policymaking, research, innovation, and financing are needed, which is why the NAM has launched this Grand Challenge initiative. And while action across all sectors is certainly necessary, the health sector has a clear opportunity, and many would argue a duty, to address its climate footprint and resilience and demonstrate leadership in this space. And the health professional community, including all of you, has an important role to play in understanding and communicating the health impacts of climate change as trusted messengers and leaders in your communities. And so with that, I'll stop and leave time for questions.
All right, thank you very much. Let me see if there's any questions in the chat. There is one so far. Do you foresee the federal government incentivizing healthcare systems to utilize reprocessing methods or reusables to get more, quote, bang for our carbon footprint? Do any policies actually exist now, or is much more advocacy lobbying required?
Sorry, Kate, it's a little hard to hear you in the auditorium.
Oh, I'm so sorry. I'm like right next to my microphone. Let's see, is that any better?
No, I don't know if it's easier for you to put it in the chat.
Can you hear me now?
Not so great.
Oh, all right.
That's better.
That's better?
Yes.
All right, I'm going to hold still then. The question is, do you foresee the federal government incentivizing healthcare systems to utilize reprocessing methods or reusables to get more bang for our carbon footprint buck? Do any policies actually exist now, or is much more advocacy lobbying required?
Yeah, I'm happy to take that. So firstly, it's a complicated issue. I don't see the government incentivizing this because it really has to do, well, not yet. I mean, I think the FDA could change their regulatory process to, we've written about this, to mandate that industry proves that something needs to be disposable, and to mandate that they have reusable options, to prove expiration dates, best use by dates are meaningful. So, that is a role that the government could have in terms of reprocessing. So reprocessing being a third party industry where disposable devices are taken, cleaned, refurbished, and sold back at a discount. Only 1 to 2% of medical devices are even eligible for reprocessing, and only a fraction of those actually get reprocessed. It's a problematic industry. I see it as an interim measure. Really, we need to move upstream on the business incentives that are driving manufactured obsolescence. The Joint Commission could have a lot to do with this, and could help by addressing how they do their surveys, and really looking toward inappropriate disposal of materials. And so that's something we're actually working with them on.
Thank you. Next question. Please comment on the need for physicians to proactively address the benefits to health and the climate for counseling our patients to pursue plant-based or vegan diets.
Well, as an anesthesiologist, I don't feed my patients, but listen, I mean, this feeds back into, no pun intended, the National Academy of Medicine addressing education and communication. There is almost no education on nutrition in medical training, and I can't speak to nursing or other health professional training, but we certainly need more of it. And training on healthy diets, vegetarian, vegan diets. Certainly moving toward whole food, plant-based diet is an essential part of wellness and disease prevention. But we also have to address the social determinants of health, right? So food deserts. So people need to be able to access whole foods, and even having them available, let alone affordable. Liz, did you care to add to that?
No, I think that's exactly right, Jody. I was actually thinking about, in particular, the last point you made, since I think oftentimes that's highlighted as a key area of opportunity, but at the same time, I think those remain accessible to a privileged view across the whole.
And hugely important. So both, moving upstream to disease prevention, investing more in primary care, financially rewarding primary care, health and wellness is really integral to system transformation. And right now, 1% of healthcare emissions is just coming from beef. So just an example of healthcare emissions. So food is a huge part of healthcare emissions, and prevention is an integral part of what we need to be doing for our global national societies.
Yeah.
Thank you. Do you have any insights on how the Inflation Reduction Act may support healthcare initiatives?
From my perspective, it's an excellent question, one that I've been sort of actually trying to follow myself to see if anyone's analyzed that specifically. And Jody, I don't know if you've seen anything in particular on that in terms of health sector specific implications. Of course, in impacting energy, there will definitely be downstream impacts on the health sector, right? But in terms of more direct impacts, I haven't seen any specific analysis.
Right. No, I completely agree with Liz. I think, most importantly right now is shifting to cleaner energy, which not only reduces greenhouse gases, reduces all those toxic air pollutants, which is the #1 national and global cause of morbidity and mortality in the short term. In terms of what specifically it can do for healthcare. So right now, as Liz mentioned, there's the brand new Office of Climate Change and Health Equity within Health and Human Services. It presently is not funded. So importantly is the Inflation Reduction Act can fund and make that office more highly functional, which will then aid healthcare system transformation. So that's what I think the most important thing will be.
So I think we have time for one more question. Does the National Academy of Medicine have resources for state level health organizations to get started on the net zero journey?
That is something we are definitely looking to collect as part of our broader work. But I know that certainly organizations like ASTO, which is the Association for State and Territorial Health Officials, for example, has a wide-ranging set of resources too for states. And I think NACHO at the city and county level has a bit more limited, but ASTO does have an existing program, and I think their own actual climate collaborative for state healthcare officials.